Morning. Time now a few minutes after 8 o'clock in the morning in Tokyo, Friday, September 24th, 2021. Welcome to another edition of the World Bank Group morning seminar organized by the World Bank Tokyo office. My name is Koichi Omori. I am Senior External Affairs Officer of the World Bank based in Tokyo. We organize online seminars introducing the latest report. By the World Bank Group economists and specialists presenting such report to the stakeholders in Japan. These online seminars are held Friday mornings almost every week. This morning, we are featuring the latest report in health sector titled Walking the Talk, Reimagining Primary Healthcare After COVID-19, which came out on June 19, about 3 months ago. Acting from Washington, we have Hui Wan, the senior economist in health, nutrition, and population global practice. Good evening, good morning to you, Hui. Thank you very much for connecting from Washington. Hope she can hear us.
Thank you, Koichi. Thanks for inviting me to be here.
Great, thank you very much. Hui took the lead in the team in charge of producing the Walking the Talk report. We'll listen to her for next 30-40 minutes, presenting the main findings of the report. Following her presentation, I'll read your question, asking her to respond. If you did not have opportunities to send your question in advance, please do so even during the seminar using online form posted on the announcement page of the seminar. Or you can simply post your question on the chat section of the YouTube screen. With that, I'd like to ask Hui to come in formally to start your presentation. Over to you.
Thank you so much. Good morning, everyone. Many thanks for the Tokyo office for inviting us to be here to present our report that was launched a couple of months ago. I'm here to represent a large team working on this report, so very honored. And I hope the presentation will give you an overview about the report and the key messages, and also make it more enticing for you to want to read the report in more details. And we welcome your feedback and any questions you might have. And if I can answer them, I'll try my best to answer them. And if there are questions that I cannot answer to your satisfaction, we'll certainly also follow up after this. So with that, let me start with my presentation. Can you please put the presentation on the screen? Thank you. I don't know why the presentation, okay, now it's coming. So what you see is the title of the report, like Koichi has introduced, Walking the Talk, Reimagining Fit for Purpose Primary Healthcare. Why, what, and how? Those are going to be the three main elements I'm presenting. Next slide, please. So yeah, this is just the structure. Let's go to the next slide. So let's talk a little bit about why, the why part, why we have to discuss reimagining primary healthcare now, and why we prepare this report. So if you're in the field of public health or global health, or you've been following up on primary healthcare, you probably already know that the global primary healthcare movement started with the declaration of Almaty in 1978. Since then, some forms of primary healthcare has been implemented in almost every country. And over this time, there were a lot of growing evidence showing PHC's capacity to improve population health outcomes and improve equity at a manageable cost. And in 2018, when it was the 40th anniversary of Almaty Conference, PHC's foundational role was reaffirmed by WHO and its member countries. The declaration endorsed PHC is the cornerstone for universal health coverage and the sustainable health system in the 21st century. However, next slide, please. Even though all these years, decades, PHC's promise has been recognized. We have seen some progress. There is a widely shared sense that PHC has not fulfilled its potential, particularly but not just limited to low and middle income countries. The implementation of PHC had many challenges. For example, inadequate financing, overstretched human resource, and weak governance and accountability mechanisms. This was known before the COVID-19 crisis. If you recall, in the 2019 UHC Global Monitoring Report, it showed that half of the world's population still lack access to essential healthcare, and financial protection is also behind. And it was clear that with the progress we had in the past, we are not going to achieve the universal health coverage and SDG goals by 2030. Then COVID came. Nobody need me to tell you how bad COVID has affected the world and affected the health system, every one of us. One important message from COVID pandemic is it has exposed the health system failures in all countries around the world. The pandemic exploited the weaknesses of the health system in both rich and poor countries. Hospitals were put on the front line for pandemic control, and many of them were overwhelmed in many countries. The crisis was made worse by PHC's weaknesses. You probably also have seen many reports, articles, news in terms of the interruption of essential healthcare. For example, vaccinations, maternal and child health interventions, many NCDs, all these chronic care. So it's mostly the low and the middle income countries again are suffering from this impact. Nigeria, for example, the data showed there were about 50% reduction in outpatient visits, antenatal care visits, and immunization. So just to say that, during the ordinary times and also crisis times, PHC, if not performing well, the world will suffer, will bear the consequences. More than ever, we need a high-performing primary healthcare system to take an active role in preventing future infectious outbreaks and other public health crises, and also responding to the long-term structural trends which we have already seen before the COVID. For example, population aging, changing patterns of epidemiology. The NCD's disease burden is increasing in almost every country. The increasing trend of urbanization and the growing use of technology and the increasing expectation for healthcare from citizens. So with this report, we hope we are not just going to repeat what needs to be done and or to redefine PHC in an abstract way, but rather based on what needs to be done, focusing more on how things can happen, how PHC can be strengthened, and to fulfill its potential. So next slide, please. I will skip this one, but if you get a chance to read the report, I hope you get into the details to have a clear understanding in terms of what we mean by primary healthcare and what is not primary healthcare. For example, we know primary healthcare, they are the platform to meet population and community health needs across their lifetime. And we also know that PHC doesn't mean your first contact of care, because you could go to emergency room for first contact. It also doesn't mean the lowest level or first level of care, which a lot of people equate as rudimentary or poor quality care. In here, for primary health care, we are really talking about an interlinked service and platform that can meet population and community health needs. And there is an architecture organizing the service delivery, and there is a governance and a financing system behind to allocate resource to provide the infrastructure, human resource for delivery of such care. Next slide, please. So from here, I'm moving to this 4 high-level structure shifts that will be required if you want to have a fit-for-purpose primary healthcare in your country. So next slide, please. The 4 structure shifts I'm talking about, I'll start with the first one, from dysfunctional gatekeeping to quality comprehensive care for all. Many of you might be familiar with the concept of gatekeeping. The concept came as more for an initiative for improving efficiency. You keep those who don't need high-level care within primary health care so that the system can function more effectively, more efficiently. However, over time, it somehow, in many countries, gets perceived as a way of preventing people accessing high quality and comprehensive care. So that's not what PHC is supposed to do. PHC is supposed to provide quality and comprehensive care for all, for everyone, especially the poor ones, the vulnerable ones. So many countries have started transforming these dynamics by creating primary healthcare teams attuned to the local realities so that everyone can have access to good quality and comprehensive care. Comprehensive, of course, is a relative concept. It depends on the needs of the local communities, and also it depends on the country context. The second structural shift we're talking about is from fragmentation to person-centered integration. Many of you or your family, your friends might have this experience that you go to healthcare providers. There are so many of them. They perform different functions. They are not necessarily linked with each other. They are not necessarily talking to each other. And for the same service, you probably face different advice. You face different cost pricing schemes, and nobody knows your situation as a whole. You are the one who coordinates your care. You are the one who navigates through the system. So in many countries, this fragmentation has really affected negatively patients' experience and patients' outcomes. So patient-centeredness and integration really become critical for for achieving the goal of health improvement. And if you have a strong performing PHC, that can be fixed. Later, we're going to talk about in more details how that can be fixed or how that can facilitate that patient-centeredness and the integration. Then here, I also want to highlight by patient-centered, we not only means that you're taking care of the medical needs of patients, but healthcare providers should also respect patients' preferences, treat them with respect, collaborate and communicate them, and empower them in decision making, and so on and so forth. So there will be a different relationship, which we will also talk about in more details later. The third shift is from inequities to fairness and accountability. The COVID-19, again, has underscored inequities in healthcare access and outcomes between countries and within countries, between different groups in the same country. You saw these news articles in terms of the disparity between in terms of access to the care, the essential health care or the COVID care or the vaccination. And you also see that accountability are at different levels. Sometimes healthcare providers, they provide care not 100% to be accountable to the people they serve. And they're also perhaps not 100% accountable to the payer, either the government or insurance company that pays for their services. So better accountability and fairness will need to be pursued through strong PHC. And the last one, but not the least, I think it needs the least explanation from fragility to resilience. COVID has told us or has shown us how fragile health system can be and how damaging a fragile health system can be to the world and to the economic cost. If you are following some of the World Bank and the IMF's research, you've probably seen that more people get impoverished during COVID-19 than before. And a lot of the poverty reduction and development outcomes that we achieved in the past years have been wiped out. So a resilient health system to build back more resiliently, more strongly, is really what the PHC, a fit for PHC, should aim for. Next slide, please. So from here, this will be the sort of the bulk part of the report, which is the how part. Yes, these concepts are not necessarily new. We know that patient-centeredness is important. We know quality is important. We know resilience is important. We need to pursue these goals, these shifts. How to achieve that? So in this report, we present this framework that these high-level structural shifts can be facilitated or promoted through 3 priority reforms. So in this slide, on the left, it is the 4 shifts that I just presented. And on the right, the triangles are the 3 priority reforms I'm about to talk. So these are based on many countries' experiences, their practices, and the evaluations, and they are, so to speak, road-tested reform steps that have proven effective and useful in promoting these structural shifts. And we use the arrows to demonstrate that relationship. Next slide, please. So I already talked about the shift 1, from dysfunctional gatekeeping to quality comprehensive care for all. And the next slide. In the next few slides, I'm just going to give you an overview, based on our literature review, our work, case studies, how each of these 3 reforms can promote this shift to quality and comprehensive care. So the first reform we are going to talk about is multidisciplinary team-based organization. So the multidisciplinary team-based organization, just based on its terminology, it means that there is a team, a PHC team, and it has multidisciplinary functions, skills, and it's linked to a defined population. And this assignment of the defined population to a team, we call empanelment. So how does that help shift to quality and comprehensive care for all? If you have a team-based model for an empaneled population, it offers what's required to provide comprehensive care for a population with various needs. For example, with the team structure, the PHC platform has additional human resource. It has more robust mix of skills, and it has a stronger mandate for defined population, because your service populations are not just come and go. It also has multiple modalities for service delivery, from facilities to communities, and also it can offer the efficiency in operation and quality assurance when working as a team. The team, by definition, come from a mix of different cadres and professions. They have clear roles and responsibilities, and they collaborate with each other. Often, the core team members include doctors, nurses, and community healthcare workers. But really, the specific compensation depends on country context and the local health needs. In the report, you'll see we offer examples on how it has been around the world. In Turkey, for example, the team also includes social workers, dietitian, psychologists. Next slide, please. The second reform we talk about is multiple professional health workforce. This is closely related to the first one. If you want to use a multidisciplinary team-based model, you need to have a multi-professional health workforce. So the transition to the team-based model requires shifts in the medical education, particularly for physicians. In the report, we also discussed interventions about exposing medical students to community-based clinical settings early in their education, providing incentives for them to choose primary healthcare as their focus, and incubating the culture for PHC providers to gain professional respect. Many countries face a shortage in PHC workforce. Team-based models will allow for more efficient use of existing workforce. For example, task shifting. If the context has very few physicians and task shifting between physicians and non-physician healthcare workers can effectively deliver a range of service from child healthcare, maternal healthcare, TB, and also screening of chronic disease. Bangladesh provides good examples in this aspect. And also, leveraging and regulating private sector workforce is often used to jointly address the gaps in human resource. Next slide, please. The third reform we talk about is the financing for public health-enabled primary care. On the financing side, high-quality comprehensive PHC, it requires significant investment, both upfront investment like infrastructure, human resource training, and also routine operations like utility, salary, commodities. Several countries like Brazil, Ethiopia, South Africa, Thailand, they have all recently increased the funding for primary healthcare, accompanied by supply-side improvements. And people may ask, how much is needed? Well, it depends on the service package that country will offer. Then you'll assess how much money will be needed. The service package needs to be explicit. It needs to be customized to the local needs, align with citizen values, and take into consideration of local resource constraints. It should be financed by government revenues, given this investment would pay large dividends and improve equity, as we will present later. Donors can also play a critical role here, focusing more on system strengthening, investing in surveillance and public health functions that have been underinvested in many countries, and aligning resource behind the government programs. Next slide, please. Shifting to person-centered integrated care. Next slide, please. So again, going back to Reform 1, multidisciplinary team and empanelment. Why this can enhance person-centeredness? Because empanelment for PHC team provides a strong foundation for care planning, coordination, and continuity, because you know who you are serving for as a provider. More likely, information and care will be organized around the people instead of around the providers. A long-lasting and trusted relationship can be established because you have this structure to keep this relationship. So in Brazil, for example, stronger PHC makes people have a usual source of care, especially in the poorer areas, so that people don't have to go randomly pick different facilities or providers, and their information is scattered around different providers. In team-based model, PHC teams also act as traffic dispatchers. They tri-agent patients and supporting them to navigate through the system and come back to PHC and the communities. So they are not holding you there as a patient, but they are really helping you to navigate to the next steps and also land back to the communities. So as I said in the beginning, oftentimes patients are coordinate care for themselves, both within and outside PHC. So with empanelment structure and a multidisciplinary team, it's more likely that patients can get more coordinated care. And also physical co-location between different providers, also the integrated IT systems can also help PHC teams to perform this role. Next slide, please. In relation to healthcare workforce, serving a defined population through a life course approach, this will require competencies and skills not necessarily taught in traditional medical classrooms. I cannot see the audience, but I can imagine some of you probably gone through medical training, so you know how the medical training is organized. And many of the traditional medical training, they cover clinical skills, but PHC, the fit for PH purposes, PHC, it needs a lot of non-clinical skills. For example, we talk about addressing local community health needs. But how do you evaluate local health needs? And how do you stratify your population by risks and needs? Which are the priority population? Which are the low risk population? And the empanelment helps to build the trust, but the trust doesn't come naturally. The human resource, the workforce, needs to build trust with the communities and the stakeholders, and they need skills for that. They need communication skills. They need to be able to reach consensus on strategic vision and new ways of working. So a lot of these skills, they are not necessarily taught in the medical class. And two sets of skills are cross-cutting in this context. One is how to use and interpret data, and then the other is the soft skills I talked about, leadership, communication, relationship building. And again, this requires a reorientation in education and training. Interprofessional education can bring different professions together early on. Traditional curriculum needs to be changed to reflect the demand for additional skills, as we said above. In Belgium, for example, community diagnosis and exercise is offered as a part of the curriculum. And the most importantly is the change in the mindset. Health PHC providers, they cannot act as authorities. They are more of partners and the facilitators. They work together with patients. So the system should reward behaviors of providers that address patients' needs, not just the medical needs, but other needs, and also reward them for managing complexity, for solving problems, and for thinking creatively. Next slide, please. In terms of financing, in here we focus on provider payment mechanism. If we want healthcare providers to be patient-centered, to provide the integrated care, the payment mechanism to the providers also need to be aligned. For example, the payment needs to take into consideration health outcomes and the patient's experience. And the payment process needs to hold teams accountable and incentivize them to do more prevention work, to do more teamwork. There are different kinds of provider payment mechanisms, and we reviewed them in the report. We also have a table sort of to compare which one is closer to the vision of fit for purpose and more alignment with the team-based model. But in general, some of them, they can provide direct incentives. For example, we make it very explicit to pay for coordination. Like France was the first one to do that. Or you can provide indirect incentives, for example, like a population-based payment and shared saving approach that is used in the United States. None of this by itself can meet all the expectations. So most likely, countries will need to use a combination of this, and how to blend them, how to mix them, of course, depends on what kind of challenges you are trying to address through these provided payment mechanisms. Next slide, please. Shifting to fairness and accountability. Next slide, please. So we talked about this, that equity is very important. And I can say inequity will always be there and likely get worse if the PHC providers, they only sit in facilities, taking care of those who come to seek care. Team-based model, if you remember, I said it has multiple delivery modality, community-based and facility-based. It also has outreach. So it has capacity to extend the care into the community, educating the community, identifying the problems early on before people identify the problems themselves, and supporting home care. There are good examples in Costa Rica and Ethiopia how they use PHC teams to engage communities. Next slide, please. And the PHC workforce also needs to be distributed more evenly to improve equity. And we know that there is a shortage, and we also know that there is a maldistribution in many developing countries. Where you need healthcare workforce most, they are not necessarily there. So in the report, we discussed how to use deployment and compensation policies to mandate or encourage professionals serving in marginalized areas. Community engaged medical education program was also discussed, where local students were recruited and prepared to practice in surrounding areas. So there's an example in the Philippines. 17 years after they started such a program, 80% of its graduates still practice in the region. Regulatory reforms can also enable telehealth's potential and make it a tool to improve access in the remote areas. Next slide, please. From the financing side, the financial barrier to access care needs to be removed. There's a growing consensus that PHC should be free at the point of care. To develop targeted interventions and allocate resources accordingly, PHC teams also need to understand why people are not using PHC, and the communities should be empowered to be part of this process. The empanelment process, like I said earlier, creates a natural structure of accountability. PHC teams need to be accountable for the experience and outcomes of the entire empaneled population. Their performance can be benchmarked with peers, with public reporting, and maybe it's the variants like community scorecards, and linked with their financial compensation from budget allocation or payment from the purchasers. Next one, please. So shifting to resilience. Over the COVID pandemic time, there were country experiences and reflections on how PHC platforms can contribute to preparedness, response, and resilience. And they can and they should perform functions like syndromic surveillance and close coordination with national public health authorities. Vietnam, for example, have relied on PHC for surveillance and contact tracing. the trusted relationship we mentioned earlier. It can enable effective communication and behavior change. Experience from Liberia and Sierra Leone for Ebola can speak to this. The trusted relationship will also be critical for vaccination hesitancy issue that many countries are facing now. Needless to say, the approach is better equipped to maintain essential service during crisis. Next slide, please. So I'm going to talk about the human resource and the financing together because they share certain features. So from both perspectives, policymaking need to be agile and flexible in order to be resilient and to respond to crisis. Trainings, finance, social and practical support like childcare, they need to reach frontline healthcare workers rapidly. Health workforce need to acquire skills for coping with emergencies in communities through their training. And people need to be able to access new services and the benefits quickly, like COVID testing or vaccination. Countries across the world have been taking actions in these areas, and many of them were documented in the report. The key is, after COVID-19, how we can embed these features into the system for systematic preparedness and resilience. Next slide, please. Next slide, please. We talked about this. So I talked about these reform steps that have proven effective. You might wonder, what does that tell me? So looking ahead, what can countries do? What can partners do? And also we reflect what the World Bank can do. Next slide, please. To reimagine primary healthcare, it has technical challenges, but at the bottom line, it's also a political problem. You know, it's a politically, it needs to be put on priority list. It requires a whole of government commitment and leadership. And also, reimagining primary healthcare is not free. We talked about this. Countries need to be ready to invest. And the numbers depends on the country context. Some countries might have already been stretched, and after the COVID, the fiscal space might get even tighter. So there needs to be collective commitment and innovation in terms of how the resource can be mobilized to invest. But we do need to recognize, without upfront investment and the investment in the routine operations, primary healthcare will not be reimagined. But you have commitment, you have investment, there has to be accountability for outcomes. Otherwise, the investment might not give us returns naturally. I don't think I need to say a lot more on this, but these are the prerequisites for any specific reform action to be able to successful. Next slide, please. So in here, we highlighted some recommendations to the government in the areas of the 3 reform areas. So for example, on the service delivery front, the service delivery model, it needs to assess the current situation and have a plan to transition to team-based delivery model. Each country has a different starting point. So there needs to be a careful and detailed transition plan. And also I want to highlight leverage information technology on the PHC frontlines to promote transparency, accountability, and team-based delivery of care. And for human resource part, we talked about how important it is to change from the pipeline of the human resource. So launch multidisciplinary medical education reform, and also reform provider compensation to promote rural practice and generalist care. And also expand the tiered accreditation system, tie them to reimbursement policy so that the healthcare workforce can be properly recognized, regulated for improving quality. And for financing, I said that many times, it should come from general government expenditure. It shouldn't come from the out-of-pocket payment from patients. And the payment reforms need to be leveraged to promote team-based care, to promote coordination, promote quality, and also accountability. Here we are more talking about the financial accountability that link the resource to results so that the limited resource can be most efficiently used. Next slide, please. So in here, we talked about some selected examples where development partners can come in. So for example, partners can come in to support the systematic documentation, evaluation, and the learning on country experience around different care models, the human resource policy, financing reforms, and so on. Partners can also work collaboratively to raise international recognition on community-based medical education and qualifications. And also partners can foster innovation, technology adoption, and new initiatives through financial support, technical support, and partnership. Next slide, please. So this will be my last slide. Here we reflect the role of the World Bank can play in delivering the promise of reimagining the PHC. So we often talk about 3 L's that the bank sees as one of its comparative advantages. We have the lending, through which we can provide financial support. So the bank will continue to work with the Global Finance Facility, GFF, and other partners to facilitate countries' easy access to funds for PHC-oriented system reforms, and also learning. So we hope the structure shapes, the priority reforms, and a lot of nitty-gritty technical skills like assessing needs, how to use data, all of these knowledges can be transferred through our work, our own work, and also the partnership, including the PHCPI, to be able to promote the learning, to build the institutional capacities in the countries, in the local context, to implement those required reforms. And also leadership. We establish a dedicated platform for policy dialogue, advice, and technical assistance to ministers of health and minister of finance. So this will apply to both the country-specific dialogue, but also collective dialogue platform across countries. I know I have taken a lot of time, but hope my presentation is clear, and let me pause here to give the floor back to Koichi, and also to answer some of the questions you might have. Thank you.
Thank you very much, Fifi, for your presentation. we received some questions from the audience. So next 10 minutes or so, I'll read those questions and asking you to respond. The first one, these questions were the questions that we received before the seminar. Would you please comment on challenges for achieving PHC in FCB, fragile, conflict, violent affected countries? What are the priority areas for action in FCB countries? How can the international society help them in these regards? This is the first question from Fujisaki-san. Thank you very much. Fuifei, please make some comment on this. Thank you.
Thank you, Koichi. This is a very, very important and a smart question. I appreciate the question. I'm not an expert on FCV context, but from the PHC perspective, I think FCV context probably needs those structural shifts a lot more than many other countries because of the nature of the country setting, right? Because the FCV settings have certain features. It often has weak governance. It often has reduced human resource, and it has a unique set of problems. For example, displacement, violence-related health problems, and mental health, and maybe some infectious disease, depending on the nature of the fragility. So I think that, again, we need to understand the problem a lot better from the angles of these shifts to identify, what are exactly the local needs, what are exactly the challenges PHC face in there, and also, really to also be innovative, because they also have poor infrastructures oftentimes. So to think about how the team-based model can be adapted to that unique setting, to those unique challenges, and how the human resource medical workforce can accommodating to that skills. And often in the FCV setting, the government revenue on services and health is limited, and partners play a very important role in there. But also without coordination, there's also a lot of fragmentation. So I do also hope that there will be more coordinated and aligned efforts from the partner side to help the countries to enhance the governance, to be more innovative, and also to provide technical assistance and bridging the financing gap. I hope this helps. Thank you.
Great, thank you very much. Let me continue reading a question from the audience that we received in advance. Community-based approach must be one of the key elements of PHC concept. Hence, the role of local government and their capacity must be equally an important element. How would the World Bank address this challenge?
Indeed, PHC is it's a very localized thing. If you hear my presentation, I also keep emphasizing that evaluate the local health needs. So that definitely requires a strong local governance mechanism extended to the PHC service delivery to improve the capacity, the governance, the accountability, and everything. The World Bank, of course, like I said, we support countries through these three sort of platforms or channels, through the lending, through the learning, and through the leadership. I think not just the World Bank, but together with partners, really, how to build local institutions capacity, the governments and the local organizations, the civil society, and to transfer the knowledge and the skills to them is very important. We can do this through the policy dialogue to put this on the policy agenda, and we can also be part of the learning agenda to improve their capacity, and also through the lending financial support to create resource and additional incentives to and enabling the environment. But I have to say that it really depends on the country context and also what the government is the overall strategic direction, to be more specific than what I just said. Thank you.
Great, thank you very much. Actually, we received more than several questions related to the private sector. The question that we received in advance was what kind of M&E system could secure transparency and fairness and accountability of the private insurance companies, since they have several dysfunctional parts to be seen as the gatekeepers of stewardship. And then same person actually asked the question related to the private sector about the role of the private sector for the PHC, particularly how we can ensure the participation of the private firms in a transparent manner. Now, during your presentation, received a question related to the private sector. Your take, if any, on the practical success cases of the leveraging private sector workforce in the PHC segment. And then another participant, Professor Yoshino, actually sent a question saying, as for the financing, would it be possible to use private sector finance rather than relying on the public finance? So we received several interesting questions on the private sector. So I'd like to ask you to make a comment on the role of the private sector in the context of the PHC. Thank you.
Thank you so much. Again, this is a very important topic. And if you read our report, you can also see that we also said that we hope the report is not only just useful for the government officials, but also for the private sector. Private sector is a very broad term. It can be the private sector. It can be the service provider from private sector. It can also be the financier from the private sector, like the private insurance company, right? And the role they play, it really depends on the landscape of a country. Some countries, they have a private sector dominating service delivery model. For example, in Korea, in many of the European countries, it's the private family practice. They are the dominant one providing the service. And in some countries, the private payers are the dominant ones. But in some countries, public payer and the public provider, they are the dominant ones. So with all these different, and then they have different combinations between the service provider and the payer. So with these different public combinations, you will have a very complex landscape to be able to say specifically what do you want the service provider to play a role. They can be complementary in service delivery. They can be complementary in human resource. They can be complementary in providing additional resource, or they can be taking a more leading role. But I would say, regardless the share, it's a 80% or it's 10%, it should be subject to the same regulatory framework. It should be subject to the same accountability framework. So it's easier said than done, because a lot of times the public authorities may not have data from the private sectors to be properly assess their performance, to properly assess their capacity. So this is really the first step that to enhance the governance and the regulatory reforms, so that there is a level field and there is equal amount of information to benchmark their performance. And also in terms of financing, again, I cannot comment on that the private insurance company, because it depends on what context it belongs to. But private insurance company should be in alignment with other payers to equally demand accountability from providers to provide high quality and comprehensive PHC for their beneficiaries. I hope this helps. Thank you.
Great. Thank you very much. Let me read the one question and one comment, and then ask you to respond comprehensively along with your final remarks. Then we wrap up a session as because of the interest of the time. So, question from Ida-san, posted on the YouTube chat screen. Thank you very much for your question. This is the excellent report. Proper financing for PHC remains a challenge for decades. What will be the keys to convince the Minister of Finance in developing countries? That's the one question. And then the comment that we received from the viewers, this is a comment from Mr. Kiyoshi Kodera. Thank you very much for your comment, Kodera-san. Let me read. I am a vocal advocate of PHC and UHC. I have no disagreement with your presentation. It is a timely reminder. However, currently, the interest of many health policy makers are swamped by faster and effective vaccination delivery and future pandemic threat. This report would have had more impact if it identified and clarified the more explicitly on a nexus between the medium and long-term PHC system building and current vaccination challenges. This is a comment from Kodera-san. So I would like to ask you, Fifi, to come in to respond to those questions and comments, and together with your final remarks comprehensively, then we wrap up our seminar. Thank you.
How do we convince Minister of Finance? Ministers of Finance are very smart, and they have a lot of priorities. I think we should turn the table around, turn the question around, and ask what are the Minister of Finance interested? What do they care, right? So we have had experience with governments who put PHC reform as their political priority. I think in those circumstances, oftentimes PHC reforms address what they care about. They care the growing health expenditure due to increasing NCD disease burden, and it's growing more than the economic growth, and it's growing even further. And they want a way to control the expenditure, in the meantime to improve population health outcomes, because currently the growing expenditure is one side, and they don't necessarily see the results, the performance of those growing expenditures. So if you can demonstrate the benefits of PHC to be improving the fiscal space, to be more efficient, and to demonstrate the results that a Minister of Finance can understand, I think there is a chance for them to be convinced. And on the comment in relation to the medium and long-term strategies, or versus the current challenges, I think PHC is it's actually a good time for us to talk about PHC at the moment that we're still in a pandemic and we're still trying to leave the pandemic behind. Because like I said, the reason that part of the reason we see the impact of the pandemic is because we don't have a performing PHC system in many countries. So so I would not put them as a dichotomy to say that let me finish conquering the current pandemic and then I will talk about PHC or talk about the long-term agendas. PHC needs to be strengthened for every reason that we are facing, to they can play active roles in surveillance, in communication, in contact tracing, in immunization. So that we should start working on PHC using the COVID as an opportunity and focusing on some of the functions that are immediately important for us to end the pandemic, but also to maintain the essential service delivery during the pandemic or after the COVID. So I don't think I'm talking about something different, but just sort of to re-emphasize that PHC is not something that you deal with it later. It really, it's really now and more than ever. I think this is important for pandemic and for beyond pandemic.
Okay, thank you very much. We had a pleasure of having Hui Pi Wan, the senior economist in health, nutrition, and global practice from Washington, D.C. This morning, presenting the main point of the Walking the Talk report. Hui Pi, thank you very much for your time. Thank you.
Thank you so much for organizing the seminar, and please do not hesitate to reach out if there is any further questions, or comments, and suggestions for us to take into consideration for the future. Thank you so much.
Great, thank you. Next week, we are going to have another special session having Robin Mearns, practice manager for social sustainability and inclusion in South Asia. He is a hiring manager for social development position, a social development specialist position, one of the 13 positions currently posted as part of Japanese National Recruitment Mission being held virtually this month. Robin is going to discuss what the World Bank is doing for social sustainability and inclusion, formerly called as a social development in South Asia. This will start at 8 a.m. On Tuesday, September 28th in Japan Standard Time. So next week, we are going to see you on Tuesday in Japan time. Once again, thank you very much for tuning in. Have a wonderful weekend. Stay safe, stay healthy, and see you next week. Thank you.